I've had lifelong contact with mental health services in the UK. The first half as a carer, with my nana receiving support for a severe mental illness, and for the last 30 years working in them as a clinician, a leader, and now a little bit of research. I've seen a lot of change and a lot of improvements. And yet, whichever way you look at it, a sizable number of people continue to feel they have limited choice. Some feel coerced, many don't have any sense of control over their treatment options. Power imbalance is often identified as the source of this problem, but there is limited understanding of what power is and how it's experienced in the mental health context. I propose this limits our ability to find solutions. We haven't fully understood the problem. To focus the research, I narrow in on the experience of power in conversations which follow self-harm in community mental health teams, considering from the perspective of people seeking and those giving help. Self-harm is an area of high public interest. There are over 200,000 UK hospital attendances for self-harm per year and rising. 60% of people don't seek any professional support, and a negative experience of help seeking makes return for help less likely. Sadly, this is linked with a risk of suicide. This is important. Now, power is a tricky concept to work with, describe and explore. In this research, I work with two co-researchers who have experience of mental health service use to address the power in the research approach and ensure recognition of things beyond my own clinical worldview. We've explored power through images created by participants, interviews and focus groups, from the point of view of people accessing and working in services. So far, our novel contributions include participants recognise power and primarily describe it as power over them, limiting their opportunities, and this includes our staff participants. And they can identify productive power, examples where they felt opportunity increased as power was shared. And they describe this as a sense of power moving and flowing between them. We've identified common movements and language for these different experiences of power, raising the possibility that our body experience, embodiment, may be a knowledge source to examine further and perhaps hold solutions. In understanding how to have more productive power conversations, we can improve experience, increase safety and reduce staff burnout. This work's likely to have impact beyond mental health conversations. With 1.7 million NHS interactions every day, this is important for all of us.